الرحمن الرحيم. الأستاذ المساعد الدكتور أحمد صلاح حميد من كلية طب الأسنان قسم جراحة الفم والوجه والفكين. Now our lecture today is osteomyelitis of the jaws. Actually, osteomyelitis it is an inflammation of the jaws, and it can be defined as an inflammatory process involving medullary spaces, cortex, and periostea. Virtually, osteomyelitis it is infection, but this infection spread to the medullary spaces or marrow spaces, and then subsequently, due to vascular supply, decrease in the vascular supply, this may lead to ischemia, and subsequently it will lead to bone necrosis. So it is virtually infection, and this infection involving all the component of bone. That means the medullary spaces, cortex, and also the periostea. The initiation or this infection usually occurs either primarily, that means there is infection, bacterial infection, or sometimes due to hematogenous spread. That means the infection spread through blood supply to the jaw bones. That means there is infection, for example, in case of the mastoid, in case of middle ear, and then it will spread to the jaw bone through the blood supply. Usually, osteomyelitis occurs in the mandible more than the maxilla, and this is due to the type of bone as well as the blood supply. As we know that the mandible, usually the type of bone is more compact bone, and little spongy bone, and as well there is little blood supply in the mandible compared to that of the maxilla. What are the predisposing factors of osteomyelitis? There are many actually predisposing factors, such as poor nutrition, chronic debilitating diseases such as diabetes mellitus, dental diseases such as periodical infection or periodontitis, alcoholics with malnutrition, impaired immunity, such as in case of also diabetes mellitus, and also patient on corticosteroids. And also there is therapeutic irradiation, because therapeutic irradiation, usually the end result of therapeutic irradiation, there is what we call end obliterative arteritis. So there is decrease in the blood supply, and also due to trauma, this may lead to establishment of osteomyelitis of the jaws. And the last one is patchy disease. Actually, patchy disease, this is due to an increase in the bone formation. And this bone formation, since there is an increase, there is decrease in the blood supply, and also due to any trauma, so there is establishment of the osteomyelitis. So, generally speaking, we can say that the main cause, either due to decrease in the blood supply and subsequent ischemia, and also trauma. For example, a patient subjected to therapeutic irradiation, and after that undergo tooth extraction. In this case, the possibility of osteomyelitis is more likely. Classification of osteomyelitis of the jaw. Generally speaking, it can be classified either into suppurative osteomyelitis or non-suppurative osteomyelitis. That means suppurative, there is pus formation. Suppurative osteomyelitis can be classified into acute suppurative osteomyelitis and chronic suppurative osteomyelitis. Chronic suppurative osteomyelitis can be further subdivided into primary, that means the secondary, the chronic suppurative osteomyelitis occurs without passing through the acute stage or acute phase. And secondary chronic suppurative osteomyelitis, that means it follows the acute phase. So primary, that means there is no acute stage, while in the case of secondary chronic suppurative osteomyelitis, it is preceding by the acute phase. Also, we have infantile osteomyelitis, which usually occurs in children. Non-suppurative osteomyelitis, actually this is abnormal bone reaction to infection. So this will lead either to bone formation rather than bone destruction. In case of suppurative osteomyelitis, there is suppuration, pus formation, and bone destruction. In case of no suppurative, there is abnormal bone reaction to infection. There is bone formation rather than bone destruction. And this can be classified into diffuse sclerosing osteomyelitis, focal sclerosing osteomyelitis, proliferative periostatis, or what we call Gary's osteomyelitis, and also we have osteoradionecrosis. So this is the classification of osteomyelitis. First of all, we are going, actually in this lecture, we are going to discuss acute suppurative osteomyelitis. Usually it is sequelae or periapical infection because as we know that the apex of the tooth is very close to the marrow spaces, so it is usually a sequelae of periapical infection. The causative microorganisms, actually it is polymicrobial. That means it is not just Staphylococcus aureus. Sometimes an osteomyelitis of the long bones, usually the causative agent Staphylococcus aureus. But in case of the jaws, it is polymicrobial. That means it's mixed. Could be Staphylococcus aureus or could be anaerobic bacteria, mostly bacteroids and Veillonella and so on. The causes of osteomyelitis could be dental infection, as we mentioned before, periapical infection, or middle ear infection, and this spread to the jaw bones through the blood supply, as we mentioned, hematogenous route. And also there is another causes of osteomyelitis of the jaw. Could be infection due to jaw fracture, or even gunshot, or even sometimes due to insertion of dental implants. So there is infection, and the infection may be progress to the medullary spaces and lead to what we call osteomyelitis. Pathology. What is the pathogenesis of the osteomyelitis? First of all, as I mentioned before, there is infection. And since there is infection, there is inflammation. So there is acute inflammation, and the inflammation is situated within the marrow spaces. So this will lead to spread of oxidate, since it is suppurative, so there is oxidate along the marrow spaces, and this will lead to cause pressing. The oxidate or pus press on the blood supply, and this will lead to ischemia. Ischemia of the bone lead to bone necrosis. Liquefaction of necrotic tissue, and this will lead to lifting of the periosteum from bone. By the way, in case of the mandible, as we said before, that the osteomyelitis usually occurs in mandible more than the maxilla. The blood supply of the mandible usually comes from periosteum and even from the central artery, which is inferior alveolar artery. So since there is pressure on the inferior alveolar artery, there is ischemia, so there is bone necrosis. And since there is liquefaction of tissue and lifting of periosteum, so there is no blood supply to bone, and also this will lead to what we call bone necrosis. Finally, it will lead to osteoclastic activity, that means bone resorption, and sequestrum formation. Sequestrum, it means non-living bone or dead bone. Here, as we can see, in case of the mandible, there is central artery and occlusion or decrease in the blood supply due to pressure from oxidate, and also there is lifting of the periosteum due to pus formation, liquefaction of the tissue, necrotic liquefaction, so lifting of the periosteum, so there is no blood supply to bone, and this will lead to bone necrosis. The clinical feature of acute osteomyelitis, there is deep-seated severe pain because the pain situated, because the infection or inflammation is situated within the medullary spaces, usually affecting the most region affected by osteomyelitis in the mandible is the body of the mandible, premolar or molar region. The swelling here, as we can see, it is indurated swelling of moderate size because usually the infection situated within the medullary spaces, and usually there is a reaction of bone formation to bone destruction. So there is bone destruction, as a reaction there is bone formation. For this reason, the swelling usually is indurated. Paresthesia of the lower lip, which is abnormal sensation of the lower lip, and this is what we call pathognomonic feature of osteomyelitis due to pressure on the inferior alveolar nerve. The oxidate press on the inferior nerve, and this leads to paresthesia. Tender, loose, or mobile teeth due to bone destruction. Exudate discharging via sinuses in the alveolar process. Actually, this is at the end stage of the acute osteomyelitis. There is pus. So also there is exudate discharging. Regional lymphadenopathy as a reaction to infection, and pyrexia, which is elevated in the body temperature. The radiographical feature, it is very important, and actually there is sometimes difficult to differentiate between osteomyelitis, acute suppurative osteomyelitis, and between the acute alveolar abscess. In fact, in the first stages, in the first days or in the first 10 days, there is no evidence, there is no radiographical feature to distinguish or to diagnose acute osteomyelitis until after 1 to 2 weeks after formation of sequacetral. Usually, there is ill-defined margin, as we can see here. There is ill-defined margin, and even here, mouth-eaten appearance. We can see there is irregularities, and this irregularities described as mouth-eaten appearance. Here also, we can see this is osteomyelitis due to periapical infection. As we can see, there is irregularity, and this is what we call mouth-eaten appearance. Later on, after 14 days, the sequacetral will be formed. Sequacetral is non-living bone surrounded by new bone formation. Actually, there is what we can see. This is the new bone formation, and this is the sequacetral. The new bone formation, it is the involucrum, and this is the sequacetral, which is non-living bone. What is the management of osteomyelitis? Actually, the essential therapy of osteomyelitis includes incision and drainage. If there is abscess, if there is pus formation, so there is incision and drainage. Then debridement to remove the necrotic tissue, and drugs. Antibiotics and analgesics also could be given. Sequacetral, if it's small, as we can see here, this is small, so it can be exfoliated by itself through the mucosa, through the soft tissue. But if it is large, like this, so in this case, it will be, it necessitates sequestrectomy. Sequestrectomy, that means incision and surgical removal of the non-living bone, which is the sequacetral. So, as we can see here, involucrum, when sequacetral is surrounded by new living bone, as we can here, we can see this is the sequacetral and surrounded by new living bone. So there is essential therapy and there is adjunctive therapy, which is could be decortication, could be sequestrectomy, could be also hyperbaric oxygen, or bone resection and bone reconstruction. This is adjunctive therapy to the essential therapy. If osteomyelitis is not treated, this will lead to the development of periostitis, soft tissue abscess, or cellulitis. So this is the end of the lecture, and thank you for your attention.